Hello, everybody, and thank you for joining us today for the kidney xenotransplantation. Are we ready for prime time? Just a couple housekeeping things before we get started. Um, this is an hour presentation, so we ask that you be on the call for the entire hour. So just a little stuff about Kidney Foundation of Ohio. We are a direct service assistance program for patients with kidney disease. We serve 32 areas and 2 affiliate chapters in Lake and Summit County. And we are one of the only organizations that has direct service in Northeastern Ohio. Today's webinar is an hour. Questions and answers can be submitted through the question and answer section as all of the microphones will be muted. We're recording this webinar, which will be sent in a following email. And for further sessions that are coming up, please visit our website at www.kfohio.org. And by signing up for this webinar, you have been added to our email list. So just some disclosures. At this time, we have indicated no financial conflict of interest with this webinar. You must complete the entire webinar and then complete an evaluation, which the link will be sent to you after this webinar by April 11th. And we have been approved for continuing education and contact hours for the nursing board, the transplant certification, transplant coordinator, and the social work board. So at this time, I'd like to turn it over to Dr. Zoe Stewart Lewis for our webinar.
All right, thanks so much. All right, I think we're in business now. Let me get into the right one. There we go. All right, I just need to see my ability to advance the slide. So welcome everyone. Thanks to Jennifer and to Annette for giving me the opportunity to talk about this topic. It's something that I'm very passionate and interested in, was active in when I was at NYU prior to matriculating here to Cleveland. So it's something that's near and dear to my heart. When I talk about xenotransplant, before we jump in too far, I do want to just acknowledge, of course, we are now into Donate Life Month. And so again, just another great month for us, lots of good events going on, and I always like to highlight that. No disclosures, as you heard. So objectives wise, I think we have to always have a context to frame xenotransplantation within. And so why is xenotransplantation sort of a relevant topic? Again, so I think to understand that, we do need to understand what is the current state of kidney transplant in the United States. And then once we kind of move in through that information, we'll talk some about what are the immunosuppression barriers that are unique to xenotransplantation. And then we'll kind of talk about where we're actually at in the current state of xenotransplantation. If others have seen me talk, you may have seen in different venues, I often share this slide when I kind of am doing some introductory framework messaging. This was a schematic that was developed out of the Scientific Registry of Transplant Recipients, or what a lot of us in transplant know as the SRTR. This is kind of the clearinghouse for all transplant data for both donors and recipients, and organ outcomes, OPO performance metrics, et cetera, in the United States. And so they conducted a patient-centered conference a few years ago, consensus conference that I was able to participate in. And out of that came this kind of schematic. And what it really highlights to me is the incredible complexity to the transplant process. And I think it's something that a lot of times when we're all very focused on our piece of this process, we can lose sight of what it's actually like for a patient who has to navigate this entire trajectory, from when they first can get referred, to getting through the evaluation process, to their transplant episode, and then their post-transplant care. And then, of course, it also brings in the complexities of the system with organ procurement organizations, transplant centers, donors, et cetera. So again, I think it's an important way that we think about anything transplant related to not lose sight of this. Um, Last year was an amazing year for transplant in the US. Each of the last sort of 5 to 6 years, there's been really significant increases in the number of total transplants happening here in the United States. So last year, there were over 48,000 transplants. Within the kidney specific piece of that, we surpassed 28,000 kidney transplants for the first time. And again, there were all-time records set for liver, heart, and lung transplants as well. Um, if we look at the year in review, so these are just a little bit more granular information. One of the biggest increases in the last few years actually has been within liver transplantation. Just a few years ago, we were doing about 9,000, 9,200 liver transplants on an annual basis in the US. And you can see last year there was a really significant jump, almost 11,500 liver transplants. That I'm going to talk a little bit in the coming piece about what has driven some of that piece specifically within the liver transplant kind of side of things. So again, overall, we do keep increasing the number of kidney transplants, which is great. Again, you can kind of see where the breakdown is if we look at liver versus heart and kind of the scale of each organ group. Clearly kidney is where there is the most need for patients and the most available organs through both deceased donor and living donor options. Unfortunately, while we're doing a lot of transplants, there's still a huge unmet need. So this schematic is showing that the pink or lighter colored bars are the number of patients who are on the waiting list within each organ. And then the red is the annual transplants being performed. And this data is from 2021, but the scale of it hasn't changed. Even though we transplant more each year, the waiting list remains, and demand and additions to it continue to pace as well. And so again, you can kind of see what I take away when I look at this slide is, overall within liver, heart, and lung, there's a fairly good match between the need on the waiting list and the number of transplants performed. However, when we look at kidney, that is clearly not the case. So there's a massive unmet need of patients with end-stage renal disease and the need to wait for access to transplant. And there's also the very sobering statistic that, every day in the US, 17 people die while waiting for an organ transplant on the waiting list. So, there's different ways to leave the waiting list. The way that most people want to think about leaving it, of course, is through a transplant. And about 2/3 of patients are going to, move through the kidney transplant wait list and be transplanted. But that means 1/3 of people are going to be removed from the waiting list. They're not going to make it to transplant. And so again, it kind of is a fairly even split between just overall death on the wait list or becoming too sick. Something happens and they no longer sort of meet the medical eligibility criteria to proceed with a kidney transplant at that time. I think that, as we continue to march along in time, we know that we are listing more and more older patients. So the proportion of patients on the waiting list who are 65 and older is increasing. And so I do think that, there's a real potential that this shift of the 1 in 3 patients not, navigating all the way to a successful transplant could increase because we continue to evaluate and waitlist older and more highly, comorbid patients each year. So what are some strategies to increase transplant? So probably the largest piece or the most impactful piece in the last decade has been increased utilization of donors after cardiac death. So deceased donors fall into 2 broad categories. The one that I think people more traditionally will think of is a donor after brain death. So when a patient has met brain death criteria and then may progress on to organ donation. But The other pathway for deceased donation is for an individual who has suffered a very significant neurological injury. And in that situation, the family has elected to withdraw life support. If that decision has been made by a family, they could be approached to be considered as a potential organ donor. In that situation, for a donor after cardiac death, the withdrawal of life support actually occurs in an operating room where they're monitored by an intensivist team in the same fashion they would be if care was withdrawn in an ICU setting. And if they do progress to heart death or cardiac death, at that point, then the process of organ donation could commence. So in the past, decade, we've definitely seen increased use of donors after cardiac death. Um, Unfortunately, or the reality, I should say, is that a lot of these are older donors that have a lot of comorbidities that aren't ideal for kidney donation. So a lot of donors are over the age of 60 that are DCD donors and come with a history of hypertension and or diabetes. And so again, even though we may recover some of those as potential kidney donors, we do see some increased non-utilization of these recovered organs due to those comorbidities. The other way we can, certainly continue to push for increasing transplant is, continuing through, events such as Donate Life Month to improve public education on organ donation. Um, Again, despite a lot of effort and really hard work in this, overall in the US, organ donation rates remain relatively flat among both living donation and deceased donation in terms of, the sort of relative proportion of the population that's participating in these. On the living donor side, some of this is that there are, what I kind of consider, or other within the field will consider, real disincentives that can exist for potential living donors. And these are sort of the unintended things that can happen with being a living donor: lost wages from time off of work, need to have, extended support maybe for childcare, maybe difficulties with, transportation and such, if you live very remotely from where your intended recipient is. So again, there's some disincentives that can exist for potential living donors. And there are some programs that are developed to try and address some of these needs, but it becomes a tricky ethical line to try and make it seem as sort of a fiscally neutral endeavor for a living donor without it appearing that a potential living donor would be getting incentivized, which obviously would have an ethical concern. There's kidney paired exchange, which has definitely made an incremental impact on living donation. So kidney paired exchange is when you have a non-compatible living donor and recipient pair. You find another pair that has that same challenge, and hopefully then you can, through large databases of such pairs, you can identify exchanges of compatible transplants that can occur. And so that certainly has been, I think, leveraged well within the last 15 years as well. And then the last and third one on that I'm going to mention here is technology to expand the use of so-called marginal organs. And so this would speak to the things such as machine perfusion devices that has allowed increased utilization of donor after cardiac death livers and hearts. And this has been, I was alluding to earlier in the talk, there's been really a huge uptick in liver transplant volume, much more so than anything I think, the field has seen for many, many years within the past 2 years. And this has been driven by our increased ability to safely transplant older DCD livers and expand that pool of potential organs. This is what kidney donation looks like. As I was mentioning, deceased donor, this has been going up, across years. This has been driven by two major pieces. One I've talked about, which is the increased DCD utilization, and the other piece has been the opioid crisis in this country that still persists. So there's no doubt that the upticks in deceased organ donation has occurred in part due to ongoing drug overdose events. And as I mentioned, you can see that unfortunately living donation has been incredibly flat and stagnant. And it's not the goal of this talk, but I do think that there is real opportunities here in this country to make massive impacts in this domain, were we to leverage the appropriate resources into that goal. Again, just another slightly different way of looking at this deceased donor data. I mentioned that, again, you know, we are seeing some increases in brain dead donors, but the curve upward is a little more steep within DCD donors. And this cutoff, this data, I think, cuts off on the graphically around 2020. And then you can see our proportion of DCD donors. I added it on here from the SRTR data. Has gone from being around 20% in 2022 up to 30% in 2024. So again, really driving up our number in that DCD pool. In terms of, I was kind of talking about how age can impact us. Again, we do know that we are recovering larger percentage or proportion of donors, deceased donors that are over the age of 55. And again, we don't want to have any missed opportunities for potential, organ donors, but by being very aggressive and recovering, every kidney from, donors up to the age of 75, clearly many of those ultimately aren't going to be appropriate for transplant. So that there is a lot of, I would say, media coverage that there's, that we are missing opportunities in this country to benefit transplant patients because of this increased non-utilization. But I think it's important to keep in mind the numerator and denominator when we have that conversation, because again, if we're doing a really good job at our organ procurement level at really pursuing every potential donor, there will be non-utilization because, again, that's the reality of going after older donors. And so yeah, I think it's a little bit depending how you want to look at it. I actually take the personal view that increased non-utilization isn't occurring because transplant centers aren't accepting kidneys that are appropriate for transplant, but that it's the fact that we're just pushing so hard on that potential, denominator side of it that's skewing that non-utilization a bit. I mentioned that the wait list on the kidney side is getting older. This is just kind of showing you, again, the 50 to 64 line clearly has a much more steeper upward trend. And same with the brown, which is 65 plus, is even steeper. So again, I think any of us who work on a day-to-day basis within the kidney transplant process are very aware. I mean, I even when I look back at the arc of my career, and I don't think I'm that old, but when I was a transplant fellow, I feel like half of the patients that I see for evaluation in transplant today, we never would have even opened an evaluation on. We would have reviewed their kind of list of medical comorbidities and said, absolutely not a candidate, and that would have been that. And now that's just a person we routinely see in transplant. So there's definitely been a massive shift, within this. And I think it's important because this is, where we know that, there is increased needs for patients. And I think with appropriate selection criteria, patients can have real benefit with transplant within these age groups. So kind of the goal of kind of going through all this data is to set the stage in the framework of, okay, what have we done to meet this unmet need and this large gap within kidney transplantation? And we really have kind of maximized, on the deceased donor side. I think there's opportunities within living donor side, but clearly we're not going to get 90,000 more living donors a year. So what are some things we could do? And I think this is where, xenotransplantation has really, been the interest, right? Could we actually have truly a full supply of organs to meet the demand of everyone who comes forward with a need? And so again, what if there was a way we could fix these problems now? Well, maybe the answer would be xenotransplantation. So to kind of think about the sort of first steps along xenotransplantation, you can drive it all the way back into the 1600s. And really kind of some of the first things that happened was using, lambs as a source of blood to transfuse humans that had a real need for a blood transfusion. And so surprisingly, there were not immediate deaths. The patients seemed to ultimately succumb for other reasons, probably whatever was driving their blood loss. Ultimately, this practice was appropriately abandoned once human blood typing was developed in the around 1900. So when I think about xenotransplant, I think there's just sort of some very basic starting point questions. Question number one is, well, what animal would be like the appropriate, model for this, right? Um, the first thought, if you think about what's sort of going to be most genetically aligned with us, would be a non-human primate. In this case, it's traditionally baboons. The challenge with using a non-human primate model is it's really not scalable. And again, it has to do when you think about the number of offspring that each baboon would have in terms of litter size, and you also think of gestational period, um, and also just the realities of non-human primate care is much more complex and expensive. So again, not something that really is scalable. I'm going to talk about this a little bit. Clearly, as we have studied pig xeno kidney transplantation, there's been extensive work done in non-human primate, models, but ultimately a lot of that hasn't really been as translatable as people would have maybe expected it to be, due to the genetic differences that still exist, between the non-human primate versus human model. And I'll touch on that a little bit more. Pigs. So pigs actually have very similar anatomy and physiology from an solid organ standpoint, but are a little bit more evolutionary divergent. But they do offer the advantages of large litter size, shorter gestation period, ability to care for them easier, and so actually does present a more scalable, realistic model. Immunologic barriers. Clearly, when we talk about transplantation across species, our standard immunosuppression that we use within human to human transplantation isn't going to be adequate. So again, there will be need for higher immunosuppression. And obviously, there was a lot of basic science that had to underlie and underpin the work to understand what were the key barriers from a genetic standpoint that had to be addressed with gene editing before a pig xenokidney transplantation could even be an option. And then probably one that people don't think about as much is the concern for zoonosis. I'm so sorry. I'm going to pause for 1 second. They're vacuuming outside my office, which they literally never do. And I fear you guys are hearing this in the background. So give me half a second. I'll be right back. All right. Sorry about that. I think vacuuming happens about once a year, and this happened to me this morning. I think we were talking about this last point. So zoonosis. Again, this is something that isn't first on people's minds when you think about what would be, sort of risks or barriers to xenotransplant. But again, it probably doesn't take any of us too much of a stress to think about that, that there could be viruses, et cetera, that could be spread from, pig xenotransplants into either the patient, which could be passed to family members, medical staff, medical equipment that's shared among patients. All of this stuff has to be thought of and considered. And obviously we know that, there's clear precedent for this from a respiratory virus standpoint. So to kind of touch some on the immunosuppression side of it. So the first thing we have to overcome or prevent when we do a transplantation and are doing our sort of blood type matching and our tissue typing matching that has to happen for transplant is avoiding hyperacute rejection. And so when we look at the pig to human model, what research found was that there are some natural antibodies that humans have that are pre-existing and pre-formed to existing pig antigens. And so again, if we don't have a way to genetically address some of these key pig antigens on the front end in the donor organ, there is no amount of immunosuppression that could overcome that. So there are sort of 6 to 8 of these, depending, how you want to define them, that are really, really critical. One of the most critical happens to be this carbohydrate epitope, which is called abbreviated alpha gal. And again, very high cell expression throughout pigs. And there's originally alpha gal knockout pigs were developed and utilized for some patients that have actually hypersensitivity to some medications that need to be derived from pigs, and or even as a food source for patients that have hypersensitivity to alpha gal. So it's actually an FDA approved genetic model for a long time. The next couple of slides, I'm going to really, really quickly summarize probably about 25 to 30 years of in massive, basic science research that happened around the world within pig xenokidney transplantation into non-human primate models. So I kind of touched on this a little bit, or was alluding to this earlier, but one of the attractive things to this model was the thought that the HLA, the tissue typing reactivity within a non-human primate model would really help guide us in knowing what would be the right immunosuppression regimen to use with a pig xenokidney into a human. But unfortunately, the sort of baboon and human HLA just aren't that similar. It really doesn't correlate. It really isn't, it didn't sort of work out in that standpoint. What we did learn, though, within that realm was even with some genetic modifications in the pig xenokidneys, that the immunosuppression protocols that they developed to allow long-term kidney graft function. So there are, pig xenokidney into baboon kidney transplants where the kidney transplant functioned for, around 2 years. So very long-term survival. But unfortunately, these immunosuppression protocols that were required for that success were profoundly more, are profoundly more intensive than what we would currently do within our allotransplant, realm, in human to human transplantation. And so again, that's a real downside, especially, if we think about the majority of our patients who are going to, probably ultimately do pig xenokidney transplantation are going to be older patients, and older patients are not going to do well with this massive immunosuppression protocol. They would, have a very high rate of, I think, infectious complications, and even, high rate of death from infectious complications. I think also some of the, kind of broad scale challenges to pig, xenotransplantation that we face is we're a little bit of, our success is our enemy, right? In that we're so good with kidney transplantation, right? Human to human and long-term survival, that we don't want to do a pig xenokidney transplant into patients and have a graft only work 1 or 2 years, because we do so much better. And so again, how would we start to figure out, the risk benefit to just waiting a few years on the wait list to get a human kidney versus doing, so we have to have the ability to have pig xenokidney transplants really last, at least 5 years, and realistically, honestly, much longer than that, given what our average allo graft survival is. And then one of the other things from all of this non-human primate work I'll mention is, some of the really important things were, derived from this work, including some of the other important incompatibilities, and genetic modifications that we should consider as we think about the pig into human model. And most of these tend to fall into things that impact our clotting factors and our clotting cascade, and ultimately, risk graft thrombosis or clotting of the graft when we transplant it. The other thing is, as we started to have some different genetic models, there's 2 different ways to do genetic modification. So One way is to just completely knock out a gene. So knocking out the gene means you completely eliminate it from the genetic profile of that animal, so they have no functional, version of the downstream product of that gene. The reason we can't just knock out all of the genes of interest is sometimes knocking out a gene in a animal model results in fatality at the embryonic stage or fetal development stage or shortly after birth, meaning it's not a viable option for survival. And so again, some of these um, genes are clearly required for survival, so you can't just knock them all out and just say here's the 8 genes that we know aren't compatible, we'll knock them all out in the pig. Well, the pig isn't a viable animal at that point. So what we have to do is have transgene expression, where you either dial it up, dial it down, or slightly modify it to produce a slightly different effector protein. And so the challenge when you start doing transgene modification is there can be variable expression over time in the animal and within the tissues of the animal and pig to pig. And so again, as you can imagine, you want to have a very clear, you want to know very clearly what is going to be the expression of different genes in the kidney you're transplanting into your patient, right? And so, again, that's one of the concerns as we work with some of these genetic modifications where it's a transgene modification, is how do we know what this is going to work? Maybe we do a transplant and it works well for a year, but then we're gonna have graft failures. All the grafts will fail by 2 or 3 years. We don't know, right? We're not that far in the process. So these are a lot of the important things we still have to work out. So as we started to think about how do we bridge this large gap that where we did all the research within non-human primate xenotransplantation, and how do we now jump across this gap and get into doing a human xenotransplant? Because again, we didn't even know the most basic question. If we put a genetically modified pig kidney into a human, would there be immediate hyperacute reaction and a devastating outcome, right? We didn't know, we don't know until you do these, we couldn't know how that would look just because of the data from the non-human primate. And so the model that I actually helped work with when I was at NYU Langone was to start doing pig xenotransplants into deceased donors, so deceased whole body donors. So the decedent human xenotransplant model really was if there was a brain dead donor identified through our local OPO, which was Live On New York, and that the donor had a clear, hard and fast contraindication to be an organ or tissue donor. So common thing would be an active malignancy, certain types of infections, etc. In that situation, the family was approached to consent for whole body donation for xenotransplant. So the NYU model, which we initially did, just again, the goal of some of this work was really to answer and sort of have that proof of concept of some of the immediate, that we could avoid hyperacute rejection and we could show sort of, early, good graft function. And so in that model, we didn't do anything with the donor's native kidneys. They remained in place, and we transplanted one pig xenokidney onto the femoral vessels, and then we could directly visualize the organ, we could biopsy it, and we could readily distinguish between the urine being produced, what was coming from the pig kidney versus what was coming from the native kidneys. In a simultaneous model down at the University of Alabama, shortly after we had started our work, their model was to actually remove the native kidneys from the decedent and then to transplant 2 pig xenokidneys intra-abdominal into the donor. So again, this is a schematic showing, genetically modified pig. We get the donor pig ultimately. There was another modification, which isn't really super relevant for the purpose of this talk, where a little of the pig's thymus was placed into the capsule of the donor kidney. And then ultimately, again, we transplanted these kidneys into the thigh of the donor. And so we did two of these first, these were the first cases. This is our article from the New England Journal of Medicine in 2022. But we transplanted these kidneys into the femoral vessels, and both the kidneys worked immediately like a live donor kidney, immediate, like real-time urine production, reperfused beautifully, no hyperacute rejections, etc. And so it really was a huge step forward for the step towards real clinical trials in non-brain dead individuals. This is a schematic again because we did follow for about 4 days. We needed to sort of keep the organ sterile and not desiccated. We were able to again easily capture the urine. And we could easily go into this to do kidney biopsies, at every 12 hours we were doing biopsies, versus if you place the kidneys intra-abdominal, it becomes much harder to have serial biopsies, etc. And this is just the first time we reperfused the kidney. This is me over here. This is Dr. Montgomery, my mentor, who I've worked with a long time. And again, just reperfusing that kidney was pretty exciting. The next step was to, again, go a little bit longer term. So again, get beyond the, okay, can we do this for a week? Really, can we get several months of stable graft function? So this was the donor for this case. This is Mo Miller. He actually collapsed very suddenly one day. And when he was taken to the hospital, he was found to have had hemorrhage, cerebral hemorrhage secondary to a completely unrecognized and unknown large glioblastoma. And so his sister was his health proxy, and she wanted to honor his desire to be a donor. And so he actually proceeded and progressed in this longer term model, his native kidneys were removed, and then a pig xeno kidney was placed and followed for 60 days. And this is just, his sister, talking about Mo, which is pretty amazing. Again, it was the same sort of genetic model, and I mentioned we did this. And again, completely normal function for 2 months. There were no signs of rejection. And again, I didn't get into the details because I don't think it's the point of this webinar here, but fairly similar immunosuppression protocol, and certainly something that can be and is realistic to do, for clinical trial purposes. So similar immunosuppression to what we do with our standard protocols now. A little bit more intensive, but not like, going to nuclear detonation of the immune system like some of the non-human primate ones required. This is the first paper done with the University of Alabama's team. And so again, as I mentioned, their schematic was to remove the native kidneys, transplant in 2 pig xeno kidneys, and then follow it. In their first transplant, they had a sort of technical complication with 1 kidney, and then really didn't see the creatinine decreasing and any significant creatinine being excreted. So initially not great function out of that first experiment. They went on to adjust their protocol a little bit in terms of immunosuppression. And then when they repeated their experiment, they with the new immunosuppression protocol, including something called eculizumab, they again saw that there was excellent graft function through a full week. And again, these are some of the biopsies they did at different time points, showing that, again, no evidence of rejection. So what is our current status? Where are we at? Where have we come since these first sort of big steps? So there have now been 4 recipients of pig xeno kidney transplants. So at Mass General, New York Langone, and then most recently in China. So Mass General is partnering with a company called eGenesis, which has a slightly different genetic model on their pig. But they've transplanted 2 patients. In both situations, the grafts worked beautifully with a fairly, again, standard immunosuppression protocol. The first patient unfortunately died suddenly at home around 4 weeks post-transplant, and it just wasn't clear on autopsy what was the cause of death. It didn't seem to be directly related to the pig's kidney per se, but again, um, and then the other patient is about 6 weeks post-transplant. So at NYU Langone, the first patient they actually transplanted was a woman who had a mechanical heart placed for heart failure, and she had and was dialysis dependent, and she was not a candidate because of her mechanical heart for a standard kidney transplant, and so she wished to proceed, and so she went on to get a pig kidney transplant, and that kidney graft failed after a few weeks, and really was thought to be from sort of poor perfusion from the mechanical heart, and again, not an immunologic issue. And then the second patient that they've transplanted is the current longest survivor. She's in the world. As of today, she is 75 days post-transplant. She has actually returned back home to Alabama. I'll talk about her in a second, a little bit more, and is doing beautifully. And then in China, in March, there was a 69-year-old female who underwent transplant with a xenokidney in China that was reported through the press in early in her recovery. So the longest pig organ transplant survivor right now is Tawana Looney. She's a 53-year-old woman. Really interesting story in that she was actually a living kidney donor to her mother in 1999, and unfortunately ended up needing to start dialysis in 2016. She had many years of uncontrolled hypertension, which damaged her remaining kidney. She was unfortunately incredibly highly HLA sensitized, to the point where despite having, 8 years of waiting time on the traditional kidney wait list here, she just was unable to find a match. And so she was actually granted an FDA compassionate use exemption to participate or to receive a pig kidney xenotransplant because it was felt that she was never going to have a human matched kidney. And again, she's done, this is her on the right, and this is her daughter with her on the left in this picture. And she's currently, as I said, 75 days and doing really well. Um, I didn't go into it again for the details of this, but there has been extensive um, work both with some genetic modifications to turn off the ability for the donor pigs to activate some of the zoonotic viruses that would be of infectious concern. And also the donor pigs are all grown in sterile facilities, which again controls, from birth onward, which controls their ability to have any exposure to any zoonotic sort of infectious risk. And so that has also underpinned all of these clinical trials and work and is present with any of these clinical trial models I'm discussing today. So for those who kind of follow the lay media stories that relate to transplant, you may have seen that there have been some pig heart transplants done. In fact, 2 of them were done at the University of Maryland. The second recipient is pictured here on the right on this picture. This is Lawrence Fawcett. Both recipients lived around 50 to 60 days before the hearts failed. The pig hearts failed from sort of ongoing chronic heart dilatation, and also probably some infectious complications as well. So there's some unique challenges within the heart because the donor pigs are not full grown. So you in the cardiac realm, as you can imagine, there has to be size matching is critical, and so you can't have the heart continue to grow once it's in the human chest, which it's been fitted to, from a size standpoint. So there is some additional genetic things that sort of have to happen to try and avoid ongoing growth of the heart. So ongoing work there though, and is active. At Penn in the past year, they did a really, I think, interesting and probably what will be, I think, the most realistic utilization for pig livers from a xenotransplant perspective. So pig liver transplantation um, has been a very difficult endeavor because of the clotting cascade and factors all sort of derive within the liver in our bodies. And so we know that this is the major challenge with the solid organ xenotransplants. And so the liver in particular just is very hard to make work in a long-term model for some of these complex clotting cascade sort of reasons. But how they utilized this was they had a patient who had acute liver failure and needed a bridge to see if their own liver could recover versus if they were going to need transplant. And so they used the pig xeno donor, which is pictured here on the right of our screen. This was actually the donor of the liver. And they put it into one of our normothermic machine perfusion devices that we use now to perfuse DCD livers. And then they connected this circuit onto the patient that had heart failure to essentially use the pig's liver to filter for the patient until their own liver could recover. And so they initially did this in this situation. It was a brain dead for the first proof of concept. But this is the thought that, again, we could use these as sort of bridges either to transplant for patients with acute liver failure, or there's situations where drug toxicity in particular, we can sometimes just need to support the patient until their own liver could recover for them. So let's see. And then in China, just last month, they published in Nature that they did do a pig to human liver xenotransplant in a decedent model. And again, we're able to show that the liver produced bile for 10 days and some of the markers, were reasonable. But again, there was definitely signs of real graft dysfunction by 10 days. So again, we're able to avoid a hyperacute rejection, but not looking like it's close to being ready for a full transplant. Again, I think there's going to need to be a lot more modifications and understanding on the liver side of things. So how close are we? I do think we have now clearly identified several genetic modified models where we can do this with a realistic immunosuppression protocol. I think we've learned how to control some of the disease transmission risks. And I think, this is what's allowed us to actually get to the stage now where there are active clinical trials in the US. So there's 2 active trials here in the US. I think each is set to enroll 10 patients. And, in the coming years, to see, how far we can take this and where the next steps will be. And again, it remains really to be seen, though, the longevity question of this. So that is all I have for today. I'm happy to take questions. Trying to see. All right. Do you want me to go through? I can like see the question and answer thing. Do you want me to, Jennifer, to start popping off on these?
Yeah, it looks like there's one question in there if you want to go ahead and answer that. And a reminder, if you have questions, go ahead and put them in the question and answer box and we'll make sure that we can address them.
Yeah. So there's a question saying, it's my understanding that LifeBank is increasing the age of accepted kidneys. Do you know if it's true? And do you see it helping with organ donation? I would say that LifeBank and, all OPOs are incredibly aggressive at pursuing potential organ donors. I mean, again, OPOs do routinely pursue donors for solid organ transplant purposes up to the age of 75 routinely. And even for liver, we stretch that into the 80s. Like, I've transplanted livers that are 83, 82, like that's not uncommon for liver. Kidney is challenging. So, it is uncommon to transplant kidneys from donors over the age of 70. Again, there's always going to be young, super ideal, healthy, occasionally, 70, but again, just statistically, the majority of donors over the age of 70, their kidneys ultimately, when we do recover them, won't look great on biopsy and won't really be transplantable. Certainly, the other thing we do though with older donor kidneys is sometimes we can use, so traditionally when we do deceased donor kidney transplantation, we transplant just one donor kidney into a recipient. We don't transplant two. Sometimes with older donor kidneys, um, we could transplant two into one recipient, and sometimes that may be an option. And again, it's tricky though, because again, I always kind of, as a tongue in cheek, but when I teach our fellows and stuff, like, two bad kidneys doesn't equal good outcome though. So again, it still has to be a donor kidney where it was all but, or you're just perhaps a little bit uncertain about enough really strong nephron mass where you might just do both. Um, so again, it's not like dual kidney transplantation will significantly broaden the number of older donors that can be used. That's a pretty uncommon piece. I see another question from Crystal saying, are there any current xenotransplants scheduled at this time, or are we waiting to see how the current recipients are doing? So there are active clinical trials. So, as with any clinical trial, there's a very careful screening, vetting process. So they are, actively, identifying recipients for the clinical trials. So the plan is to do 2 different clinical trials, each with 10 recipients. That's the current trials. Can you speak, Suzanne has asked a question, which is great. I didn't dive into this, but can you speak on the advancement of ethics and the considerations as pig human technology and makes more polished? I mean, I'm not certainly an ethics, I guess, I think it's like anything. The ethics of it are, I think, probably no different than the ethics of, um, pigs as a source of food, for example. So, and we use them as sources for, other medical pieces, within, heart valves, etc. So again, I don't have specifics on that. I'm not seeing any other questions right now. We have a
I
couple
think
minutes left.
one
Yeah.
question I see is it says in like the next 10 to 15 years
Oh
from
yeah.
now, do you see xenotransplant being the norm?
I don't think it's going to happen that quickly, and I think the reason is, I think I think where I see it becoming the norm would be for people that just don't have an option, right? So, for example, if you're 68 years old and you had a recent colon cancer a year and a half ago, and you're on dialysis, you don't want to wait 5 years to get your kidney transplant at that age, right? Or so you may elect to go forward with a xenotransplant. Because again, and again, when you have a solid organ malignancy, you would traditionally have to wait 5 years before we could do transplant to sort of have that proof that you're not going to have recurrence of your malignancy, and et cetera. So, so for someone like that, where again, they don't have a path forward in any sort of timely fashion to transplant. And the reason I think it won't be standard of care in 10, as I said, is we know how good our outcomes are with allotransplantation. So again, if you're a patient weighing the pros and cons, you have to have a pretty compelling reason. And you have to be someone like Tawana, where your team is determined you're just not going to realistically match a human kidney anytime soon. Then it makes sense to I think proceed down that pathway. But if you can pursue a living donor, or if you can wait, hopefully what our system can do too is continue to do better job of getting patients listed preemptively for their waiting time. And then patients can hopefully wait more in a preemptive status and minimize that dialysis time, and then get an allo transplant that they can feel more confident it's going to go 15 to 20 years for them versus the unknown of a pig kidney.
And I have a question. I don't know
Yeah.
how advanced things are at this point, and obviously this is so new, but within regards to like the liver, the xeno liver, you said that, that's kind of right now you guys are looking at that to be kind of like a holding situation just until like a liver is available. Do we see this possibly with like uh, kidney as well, that it can be kind of like a bridge um, until a kidney becomes available so they're not doing dialysis? And is it
Yeah, great question.
possible to transplant uh, human kidney into a person after they've had a pig kidney?
Yeah, so really that's actually a really complex question. And the reason is I think it's hard to say that it's a great bridge option. And the reason is it takes strong immunosuppression, right?
Mhm.
So it's less it's I mean, it is more immunosuppression than we use now for standard human to human transplant. And we know there's real risk with human to human, immunosuppression actually. So there's just that immunosuppression risk is a real thing for sure. And then we also know that even though the pig HLA is different than human HLA, once you're exposed to that pig kidney, it will be harder to match a human transplant. And we don't understand how much harder yet. So technically, of course, we can put another kidney in a patient. It's all about what happens to the immune system once it's been had a pig xeno kidney in it for a couple of years. What is it going to look like when we try to run an allo cross match for that patient? We don't know yet. Because your immune system, when it's stimulated, even though it's not stimulated by human HLA, can still have that response that can generate things. So there's a lot of unknowns there.
Great. Well, thank you, Dr. Stewart Lewis, for this presentation. I think it was very interesting to kind of see where things are, where things are going, and kind of the future for xenotransplantation. I just want to share that we have, let's see if we can get to the, all right, so I will share that there are several webinars that are coming up. After this session, you will get an email that gives you information about the upcoming sessions. Um, there's also an email with the link for the evaluation. So I ask that you complete the evaluation. If you used a phone number, please be sure to put that in on the evaluation so we can give you credit, and your certificates should be out by next week. So thank you all very much for being on this. And if you have any questions, feel free to email me. Everyone enjoy the rest of their day.